Hello everyone, welcome back. Today we are going to speak about the eye. So let's take a look. So, regarding our eye, first thing first, you need to understand how the eye works, the mechanism of the eye functioning, and how everything in the eye goes together. You must know the anatomy of the eye, you must know the physiology of the eye. So to start with, oh, wait a second. So in first aid, now they switch it over. So now the ear comes first. So let's finish the ear and then goes to the eye. If you are planning to become an ENT doctor, this is for you. So let's try to understand what is this all about. So regarding the ear is subdivided into three main sections. So we have the external outer ear, we have the middle ear, and we have the inner ear. Each one of them has really important function. So if we speak about the external outer ear, the main idea is for it to condense the sound. So it's just like an object that is going to condense the sound into a smaller area. The smaller area is also a part of the external ear, and it's known as the external auditory canal or external acoustic meatus. External acoustic meatus, that means that there should be something called internal acoustic meatus. Anyway, the external auditory canal propagates the sounds until it reaches the eardrum. The eardrum is just a membrane, and when that membrane get hit by the sound wave, what will happen? It's going to vibrate. This vibration is going to lead to basically the movement of these three little bones. So we have three bones known as the ossicles, and these ossicles, they are going to work on the oval window, and that oval window, basically the main function is to amplificate the sound. What do I mean by that? Well, the tympanic membrane, let's say it's this size. This is the tympanic membrane. The oval window is this size. Actually, it's 20 times smaller than the tympanic membrane. So basically, it's going to accentuate the sound one more time. So the auricula did it the first time, and the second time it was done by the ossicles. Okay, now the sound has been converted from being transmitted by air into being transmitted by bone. Okay? The next thing that is going to happen is that it's going to vibrate, and that will lead it to move inside of the cochlea, which is going to move inside of a fluid known as endolymph. So far, the sound moves inside of air, bone, fluid, right? And also in the semicircular canals. The general idea, just in general, this is not 100% accurate. The cochlea is responsible for the sound, and the vestibula and the semicircular canal are responsible for the balance and the balance and sensation of stability. Okay, good. There is also one more opening that is here, as you can see, and it's also known as the acoustic tube that connects the nose to the ear. Okay. So this is the general structure of the ear. Of course, there is much more than this. So the next thing they are speaking about now is the outer ear. Is the visible portion of your ear, the pinna. They write include auditory canal and tympanic membrane. It transfers the sound waves via vibration or of the tympanic membrane. So the transmission is happening through the air. So I have a question. Can somebody in the space hear? Can somebody in the space hear? Or in the space it's impossible to hear something? Exactly. It's impossible to hear anything in the space. The person will be in front of you and he will be like, hello, and you will hear nothing. So in the water, however, you might be able to hear a really dim sound because still there is a medium, there is water. But if you speak about the space, there is zero sound, okay? So The next things goes something like this. The middle ear. Air-filled space, the middle ear, with the three bones. The malleus, meaning a hammer, oncus, and stapes. Oncus is like a uncus, which is like a navel, you know, and the stapes. So these are the three smallest bone in the body. The stapes is the smallest between them. So it is the smallest bone in the body. Ossicles conduct and amplify the sounds from the tympanic membrane to the inner ear exactly at the oval window, which is 20 times smaller than the tympanic membrane. Quick question. As we saw, the tympanic membrane is really important. If a really bad explosion happens next to my ear, will it burst? I mean, will the tympanic membrane just rupture? The answer is yes. Okay, so if it ruptures, what to do? I mean, will it, is it fixable, or the sensation, the deafness will be permanent? Is the deafness permanent or not? It's fixable. You can do surgery. It's possible to do surgery to make the healing go faster, but even without surgery, it takes a long time, like 6 to 9 months, but it's reversible. Basically, the tympanic membrane can regrow. Okay, so nice. But yeah, so basically the tympanic membrane can regrow. That's the take home. But it takes time. So the next thing is a snail-shaped snail, right? You know it's a snail. It's like this little animal that's disgusting. Yep, a snail-shaped fluid-filled cochlea. The fluid, we call it endolymph. I don't know if they mention it, but write it down, please, because they do ask about it. Endolymph. So it contains basilar membrane that vibrates secondary to sound wave. What does that even mean? Let me see. They don't have a picture about this, so I have to show it to you. There is something inside of our ear called our organ of Corti. So our organ of Corti is located inside of the cochlea. Basically, this is the cochlea, right? Let's take a cross section of the cochlea. It will look like this if you just cut it, right? So it will have something called scala vestibula and scala tympani, and there is this thing in the middle that we actually care about. So you can see here it's something called the tinctorial membrane and this other structure. You can see this hair cells, we call them, right? The hair cells. These are the one destroyed in old people. You know, when you speak with old people, they cannot hear you except if you scream. Why? Because their hair cells are destroyed because of age-related issue. Okay, so basically when this little hairs gets stimulated by the tympanic membrane, this tinctorial membrane, it's going to lead to vibration of this little hairs, and that is going to lead to a sensation of the sound. Basically, to create action potential inside of the hair cells, which will lead to the sound formation. Okay, so this is how the cochlea looks like. You can see the oval window if you remember, and there is the round window. The fluid is going inside of the passages, and as you can see here, from like the oval window, which is oval window is the auditory one. It's going to go to the tinctorial membrane to stimulate it to promote the sound formation at the hair cells inside of the inner ear. Old people, they cannot hear loud sounds. They cannot hear low sounds because of that. So they write, vibration transduced via specialized hair cells that I just show it to you. And yeah, and then auditory nerve signaling happens to the brainstem. Make a note, please. Regarding the specialized hair cells, there is the following point. The hair cells, when they are getting stimulated, they are going against what? They are going against this tinctorial membrane, right? That's one thing. And the other thing to appreciate, I hate when this happens. I just wanted to say something, but I forgot it. When I remember it, I will say it back. Basically, they can go to the cranial nerve number 8, vestibulocochlear nerve, which goes back to the bones. Okay, each frequency leads to vibration at a specific location of the basilar membrane. So if you say it's different than hearing a, so Different levels of sound can be creating different type of vibration, and that means they are going to affect different areas of the basilar membrane, which means that you will be able to hear sounds at different levels. I know this might sound stupid for some of you, but it's kind of not so important, not low yield at the same time. I've seen a question on this. So, low frequency sounds are heard over the apex near the helicotrema, which is a portion basically of the inner ear. It's not mentioned here. Let me show it to you. Okay, so you remember we had this cochlea, right? And if you keep going, boom, 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 the last portion of it, that's our friend. This is the helicotrema, okay? So that's the helicotrema. So when we are speaking about sounds that are considered to have low frequency, like whom? Like Morgan Freeman. He has this really deep voice, so that is going to be more near the helicotromy. Yeah, Morgan Freeman is going to hail helicotromy. Okay, so high frequency heard best at the apex of the cochlea, however. Okay, so that will be thin and rigid sound. Types of hearing loss: we have noise-induced hearing loss, which is what we just spoke about. That can happen, well, it can be explosion, or somebody who had some form of major trauma due to something like blowing next to his ear. So damage to the stereociliated cells in the organ of Corti, but this is actually not the same as the bomb. This is different. This is a little bit different. Noise-induced hearing loss, it means like somebody who was in the nightclub all the time, okay? So damage to the stereociliated cells in the organ of Corti, which is basically the cells, the hair cells we just spoke about. So you will lose the high frequency sounds first, and sudden extremely loud noises can produce hearing loss due to the tympanic membrane rupture. So yeah, basically two types. If it was chronic exposure to the sound, you will have a high frequency hearing loss first, basically people who go to nightclubs a lot, or DJs. And the sudden hearing loss is the soldier who came back from the fight and got his tympanic membrane rupture. Tympanic membrane rupture will make the patient really disoriented and having this really bad feeling because he's going to be overstimulated basically. Presbycusis, it's an age-related progressive bilateral sensorineural hearing loss. It's a little bit different from the noise-induced one. The noise-induced one is going to be seen in people who are young. Okay? So, it's due to the destruction of the hair cells we spoke about at the base of the cochlea. So, they will preserve low-frequency sounds at the apex. So, if you speak with this patient, this they consider the the feminist hate basically. It says like they say they can hear the man voice but they cannot hear the female voice because men tend to be low frequency sound while ladies tend to be high frequency sound, which basically that old man that cannot hear his wife, she's complaining about that, but it's okay, basically cannot hear her because she's high frequency. Okay, so high frequency sound, by the way, it's something like this type of thing, like this. Their sounds is just weird. And high frequency sound is like this more masculine, more deep type of voice. Okay, so diagnostic. Okay, so basically they're like this one. There is this ringing fork, we call it the tuning fork. Let me show it to you. They like this one. It's still used in the clinic. It's cheap and it looks like this. Basically what do? That you grab it here and you just release, just squeeze and release. It's going to start vibrating. Okay, so what should I do with it? Well, this little device can help you determine where is the problem. Is the problem in the conduction system, or is the problem in the nerve or in the inner ear itself? The way to differentiate between these is actually a little bit more complicated than you think. You have to do something called the Weber and the Rinne test. So the Weber test is the first test, and it basically tells you if you do have a problem or not. It does not tell you exactly where is the problem. It does not tell you exactly where is the disease. It just tells you that if you have a problem or not. As simple as that. So when we speak about the Weber test, tuning fork, it's put in at the vertex of the skull, at the top of the skull basically, and you ask the patient, is it more on the right or on the left? I mean the sound. And he thinks, and he's like, well, they are the same. You are like, okay, good. So then the other person, when you check for him, he says, well, actually, doctor, on the left it's amazing, but on the right I cannot hear anything. Okay? So they write here, localizes to affected ear, decrease the transmission of background noise. Okay, let's speak about this. So basically, on this ear, the healthy one, okay? So you can see the disease here. So the healthy one, what do we hear from it? We hear two things. You hear the external sounds, like my freaking cat meowing outside, and my neighbor with high music, and this, the tuning fork, right? So you hear two voices. But from the other ear, this conduction system is messed up. So the patient is suffering from conductive loss, right? So he has major hearing because he only have one sound transmitting to him through the tuning fork. So that's why he says, oh, doctor, actually on my right ear, it's really good. On my left ear, it's really bad, okay? Because the right ear is actually, the conductive system in it is affected, okay? So that's conductive hearing loss. Sensory neural hearing loss, however, it will be vice versa, meaning that the right ear will be affected, but the sounds will be absent. So, sorry, the sounds will be more in the left ear. Why? If the inner ear is affected, that's destroyed. There will be no bone transmission. But in this case, in the conductive one, regardless of the destruction of this portion, there was direct bone conduction into the inner ear, which allowed the patient to hear. So, I repeat, this is important. You bring the tuning fork. The first step to do is to bring the tuning fork, put it at the vertex of the head. If the patient hears it equally on both sides, what you need to think about? If it's equally on the both sides, it's nothing, exactly. So if it is going to be like the patient has a right ear problem, okay, right ear problem, but on the test, it shows that he has hearing of the sounds more on the right side. I mean, after the first test, the Weber test. It's a conductive hearing loss, absolutely, because on the, why does he hear better on the affected ear? Why it's better on the affected ear? Because the inner ear is intact and no external noise to ruin it for him. Exactly. Yes, and goes directly through the bone. Nice. Guys, a tricky question. Just make a note about it. I will tell you now. Normally, air conduction is better than bone conduction. Make a note about that. It's commonly misunderstood. People think bone conduction is better than air conduction. This is not true. Okay? Air conduction is much better. If you want to prove, try to put your lips on somebody's head and say something directly. Or better, scream at his bone and then scream at his ear and see which one will be making the higher noise. And that's when the Rinne test comes. So you have your theory. It's either, you know for sure the patient has a problem, but you are not sure which ear is affected, you know? Yes, you see lateralization to one side, but it's difficult to say, well, which area is actually affected. So that's when you do the Rinne test. So turn tuning fork in the front of the ear to check for air conduction, and for air conduction, and then air conduction is AC, of course. And you keep it in front of his ear until he says what? No, actually, I made it vice versa. I'm sorry. In the Rene test, they write here in front of the ear, blah, 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 blah. On the master. Okay, there is something wrong here. They make it vice versa, guys. So learn how to do it, because this is written poorly. Basically, when you take the tuning fork, I told you that the air conduction is much better than the bone conduction, correct? So logically, which one you should start with? It's going to be logically the bone conduction first. So you start with the bone conduction until the patient cannot hear it anymore. When he cannot hear it anymore, you do nothing. You just move it in front of the ear. He will keep hearing it a little bit, okay? Because air conduction is better than bone conduction. Okay, if that is the case, the patient is okay. He's completely normal, okay? Okay, so let's say that this is not the case. So again, what they write here, the tuning fork is in front of the E, that's air conduction, while when you put it on the mastoid process, that's the bone conduction. So again, you put it in the mastoid process and then you move it in front of the ear. So bone conduction is better than air conduction. Oh, well, when that will be conductive hearing loss. So in case of conductive hearing loss, this pathway is messed up. Just imagine it like rupture of the membrane or a foreign body in here. Something wrong is in this area. So when you do the air conduction, again, the bone conduction, you start with it, he hears normally. But when you put it in front of his ear, can he hear it anymore? When you move it from the bone to the air, he's not going to hear this anymore, which means it's a conductive hearing loss. The third one is going again, air conduction is better than the bone conduction. This one tends to be a little bit tricky, because the patient, when you put this for him, he will be like, do you hear it? He's like, yeah, I do. Okay? And then you move it to his ear and it will appear like it is normal. You're like, wait a second, how the hell does it appear that it's normal? Well, this is the most trickiest portion of the USMLE actually, because it used to trick me. So I was like, how the hell, if he has destruction of this guy, does air conduction allow him to hear, but the bone conduction does not allow him to hear? It took me 1 year to discover the answer. So the answer basically that in case of bone conduction, it's bad. Why? Because he has sensorineural hearing loss. It's not working. He cannot hear. But why at the conductive, at the air conduction, it's good. Like he hears something. He hears something because the sound in air conduction is transmitted by what? Air. Air. It's transmitted by air conduction. Right? So it's going to be transmitted by air all the way until it reaches the other ear. Got it? So it's going to move all the way until it reaches the other ear, which means that the other ear will hear the sounds, making it look like air conduction is more than the bone conduction, but it's not real. So again, you have your patient. First of all, the first test is the Weber test. If you forget which one is the Weber, just write a big W in the head, and that reminds you of Weber. So you put it at the vertex, you check the localization. After that, you do the Rene test. Remember, start with the bone before the air, and accordingly, you can make a diagnosis if it was conductive or it was sensorineural. The next disease is cholesteatoma, which is a type of tumors, quite famous in the USMLE. It's an overgrowth of a desquamatized keratin debris, and they will tell you that the tissue contains keratin debris. Basically, this tumor, it's a tumor of the middle ear, okay? And it's going to lead to this massive growth. And which type of hearing loss do you think? Is it sensorineural or conductive? Conductive hearing loss, I agree. So let me try to be tricky. This is the right ear and this is the left ear. So if the patient has the cholesteatoma on the right ear, Tell me please, on the Weber test, which ear is going to have the lateralization of the sound, basically? The right side, exactly, because there is no background sound, right? Okay, nice. What about on the Rinne test? Rinne test? Is it going to be air conduction more than the bone conduction, or bone conduction better than the air conduction? Bone is better than air because it's a conductive hearing loss. Excellent job, guys. So it can be congenital or acquired, secondary to recurrent or chronic otitis media. It may erode the ossicles and destroy them. Mastoid air cells as well can be affected, which are located behind the middle ear, and that can lead to conducting hearing loss. I keep saying in front, lateral, medial of the middle ear. So what's up with that? Well, the middle ear, I want you to think about it as a box, okay? This is the middle ear. So what is located around the middle ear? The middle ear is like a room. It's like a box. Imagine yourself in a room. At the front wall of that box, what are you going to have? The acoustion tube, right? At the medial wall of that box, you are going to have the oval window and the round window. At the posterior, so okay, I hate to draw all of them together, but this is oval, round, and this is the acoustion tube, right? And the posterior wall, you are going to have the mastoid's air sacs, and under it you are going to have the jugular vein. Laterally to it, what is this? What do you think will be here? Laterally is going to be the tympanic membrane, okay? Tympanic membrane. Okay, and superiorly, it's going to be the temporal bone. Temporal bone. So again, medially, foramen, the round and the oval foramen, acoustion tube anteriorly, superiorly temporal bone, inferiorly jugular vein, posteriorly mastoid air sacules, and laterally it's going to be the tympanic membrane. Okay, good. Often it presents with a painless otorrhea. That's the cholesteatoma. They only tell you about the keratin debris in the test. So, and they want you to know that it's not a sensory neural, but a conductive hearing loss. So vertigo. Oh, what is vertigo? It's when the patient feels that the world is spinning him around. So it's a sensation of a spinning while actually being stationary, meaning sitting in your place, standing in your place. Subtype of dizziness, but it's not lightheadedness. Lightheadedness is when you stand up and suddenly kind of become haziness, unconsciousness. You just feel like you are going to drop. But vertigo, you feel that like the life is spinning you around. There is two types of vertigo, the peripheral and the central vertigo. The peripheral one is much more common. The central one is much more dangerous. So peripheral vertigo, it's due to an inner ear pathology such as a semicircular canal debris, like in case of benign paroxysmal positional vertigo, which is pretty cool actually. So let me speak about this benign paroxysmal positional vertigo. Why it's pretty cool? Because you can treat it in the clinic. I mean, the patient will not need surgery. He will just need a minor intervention that will allow him to become totally healthy in a matter of seconds. So let's take a look at this patient. Just wanna show you this little video.
Informing the brain. Normally, only with head movement does fluid within the inner ear also move, informing the brain that a head turn occurred.
Semicircular canals.
However, should a crystal called an otolith gets displaced into the posterior canal of the inner ear, BPPV dizziness occurs. Fluid movement occurs due to the crystal rather than head turns, causing the brain to think movement has occurred even though none has happened.
Notice the pupil nystagmus.
The Epley maneuver is performed to treat this posterior canal BPPV by trying to get the loose crystal out of the canal. This maneuver is started by turning the head 45 degrees and the body laid back such that the head is extended about 20 to 30 degrees. If BPPV is present, eye twitching called nystagmus will occur.
So as you can see, the nystagmus can confirm the test for you. So you make the patient lay down and tilt his head towards where you think it exists. It's okay. Like if it does not exist on the right, it will be on the left. So how to tell? Well, it will be when the eye do the nystagmus. That's confirmatory. When this happens, just continue the maneuver and do the ablay maneuver. The ablay maneuver will cure it. How? Let's see.
After 30 to 60 seconds, the head is turned at 90 degrees to the opposite side and held for another 30 to 60 seconds. The head is then further rotated another 90 degrees, accomplished by having the patient turn onto their side, which is then held for another 30 to 60 seconds. At this point, the head should be turned 45 degrees from the horizontal. When performing this maneuver, another individual can help with these position changes. The maneuver is then completed by having the patient sit up. So what's going on with these position changes? Essentially, the head is moved in such a way to manipulate the crystal to fall towards the canal opening. With each position change, it takes about 30 to 60 seconds for the crystal to settle into the most dependent position in the canal. If turns are made before the crystal has a chance to settle, the crystal may fall back the wrong way and the maneuver will fail. It's also important that the head positions are angled correctly, or else the crystal will not settle to the correct position in the canal and the maneuver will fail. Also, if the position changes are done too slowly, the crystal may not settle quickly enough from lack of momentum and the maneuver will also fail. Once the crystal falls out of the canal, the dizziness should resolve if due to posterior canal BPPV.
Okay, don't worry about the crystal so much. It will be cleared out by the venous system, which means the patient is cured. So no need to worry about anything. Okay. Let's have 10 minutes break. I'm going to kick out some cats. So see you in 10. Recording again. I had to deal with some unexpected cat visitors. So this PPPV, if they ask you how to treat it, and it's really common to get this question, what you will answer? The answer is going to be just a moment. Yes, repositional maneuver. Okay? Yep, repositional maneuver. So the Meniere disease, vestibular nerve infection can also lead to vertigo, but still this is peripheral. It's not affecting the brain himself. Meniere disease, it is really bad disease. It's like the worst thing you can get. I like to think about it like idiopathic intracranial hypertension, but for the inner ear. So Meniere disease, a triad of sensory neural hearing loss, so they cannot hear. At the same time, they have the vertigo, and they have this ringing of the ear, like zzz, that's tinnitus. And the endolymphatic hydrobus. Remember, where is the endolymph located? Where was the endolymph located? We spoke about it. In the cochlea, absolutely. So that increase of that amount in the cochlea and in the vestibula is going to lead to these symptoms. So increase in the lymph within the inner ear. Okay, so it sounds similar to increased intracranial hypertension, right? So the treatment is with the antihistamines, because in an indirect mechanism, they decrease the secretion of the endolymph. Think about endolymph as CSF, meaning that it's something that is made inside of our, like inside of these tubules, right? And is going to stay within them. So our goal is to decrease the amount of the fluid. So there is multiple ways of doing such thing. Anticholinergics can be utilized because they decrease the vertigo itself. The most commonly used anticholinergic to decrease the vertigo is called scopolamine. scopolamine, okay? Scopolamine is mostly used for people with seasickness vertigo, but still it can be utilized in other causes. Antiemetics, only symptomatic because, the people will be vomiting as hell. And can somebody tell me any antiemetic that you know? Any drug that decreases the vomiting? Ondansetron, metoclopramide, and others. Yes. So, and the brebitant. Yes. Low salt diet, because less salt, less water, less water, less fluid, less endolymph. And diuretics. Which diuretic? Acetazolamide, most likely. They decrease the production and increase the clearance. And ablay maneuver, only in case of PPPV. They are not that nice. They will never tell you ablay maneuver. They will tell you repositional maneuver. Central vertigo, the problem in the brain himself. So the problem either in the brainstem or in the cerebellar lesion. So remember, the cerebellum is responsible for the balance. So the patient is going to have absence of the balance. So they write stroke affecting vestibular nuclei, or it could be due to a demyelinating disease. Can anybody tell me any demyelinating disease that you know? Multiple sclerosis. Excellent. Progressive multifocal lycancephalopathy. Good. Guillain-Barré syndrome. Awesome. So we have so many demyelinating disorder. Oroposterior fossa tumor. So cancer of the posterior fossa as well can lead to central vertigo. The finding will be a directional or purely vertical nystagmus. Let me tell you this trick. So when you take a look at an nystagmus, if it's going like this, up and down, 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 think CNS problem, okay? When it's and we call it vertical nystagmus. But if the eyes are going right and left, 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 that's horizontal nystagmus. Most likely it's going to be peripheral, okay? So horizontal nystagmus most likely to be peripheral. Vertical nystagmus is most likely to be central. Just think about it as the patient is having a look at his brain. He is looking up. So the findings is going to be directional or purely vertical nystagmus, skew deviation, which is basically the misalignment of the eyes. Basically, when you take a look at the eyes, they will not be at their normal place. So it will be something like this, okay? And also, they can have double vision because of that, and dysmetria. This dysmetria is quite interesting because this patient, they can tell you something like, you just enter the room and you are 4 meters away from the patient. Be like, doctor, be careful, you almost hit my face. Yes, so they will have some serious problem with measuring the distances. However, their vision is normal. Well, they have the diplopia, but it's overall it's normal. Okay, these cats are just annoying. Sorry for that. Focal neurological finding can be appeared as well because of the compressive effect. So the next thing is going to be the eye anatomy. So the eye is composed of 3 layers. So these layers are going to be the outermost layer, the middle layer, and the innermost layer. Each layer has a function and it has a story. The outermost layer is the protective layer, and that's what I want you to understand from it. It is composed out of the cornea anteriorly, which is the portion you see, and the sclera, which is the white stuff. So if you take a look at the eye, the cornea is the transparent thing that exists here. It's not the brown one. The brown one is the iris. The transparent one, the one that you cannot actually see, that's the cornea. Can we transplant corneas for people? Absolutely, yes, we can. Well, this is a tricky question. Can we transplant corneas from dead people that died like 1 day ago? Which is considered a lot of time for a dead person. Yes, we can. The cornea, our cornea, is the last thing in your body to die. Okay? That means we can have a lot of corneas. Which infection are we are really scared of in case of corneal transplantation? Oh, nice. Somebody knew it. Okay, bryons. Bryons, absolutely correct. Good. So the next thing we have here is, so we said about the outer layer, and now we goes to the middle layer, the choroid layer. The choroid layer is full with the blood vessels. So the main functionality of the choroid is for the perfusion and the blood supply for the eye. The inner layer, however, is the retina itself, and it's the one responsible for the perception of the lights of different types. So this is the retina, but let me make it in this shape, like a round shape. In our eyes, we have two types of photoreceptive cells. We have the cones and we have the rods, right? So how they are distributed? Are they all over the place? The answer is no. So the cones will be mostly centrally located, okay? And they are responsible for color seeing. Good. So they are mostly centrally located, the cones. What about the rods? Rods, there is only few that are centrally located. They are most likely to be in the periphery, okay? Nice. So how this is useful, please? Well, during the night, look at something. Can you determine the color of something in the dark? I mean, you can see its shape, you can see that it exists, but can you tell exactly which color it is? The answer is no. Why? Because which cells are working and which cells are not working? Exactly, because the rods have much more surface area location, they even work at more darker situation. The cones need optimal situation. Okay, so the choroid is the area responsible for the vascularization, while the retina is the area responsible for the perception. All of the info from the retina will be going into the optic nerve and then to the chiasma optica and to the brain. Inside of our eyes, we have an anterior segment and a posterior segment. The lens differentiates between these two areas. In the posterior segment, we have something known as the vitreous chamber, which contains the vitreous jelly, okay? And then we have this area. This is the iris, okay? It's the one, you say somebody has blue eyes, green eyes, brown eyes, doesn't matter. All of this eyes color is the iris color. So, people with a blue eyes, do they have any pigmentation of their iris, yes or no? No. So basically, the iris is the only iris is normally blue in all of us. All of us have blue eyes, guys. Just some of us have developed myelination of our iris, and that caused it to become brown. So let's take a look. Here you can see the zonular fibers which connect the lens into the ciliary body. I know that you must have forgotten about this, but which type of collagen is the lens? If you forgot, it's okay, but which type of collagen is lens? No, it's not type 3, it's actually type 4. Remember, it's 4 letters, so it should be type 4. Remember Albert syndrome, defect in the collagen type 4, and we had a disease of the lens known as lenticonus, right? The lenticonus, which is an anterior projection of the lens like this. Okay, so the pupils is the opening of the iris, as you can see, and you can see here we have an anterior chamber anterior to the iris, and the posterior chamber posterior to the iris, okay? So, if you get a weird question asking you, where is all of this fluid inside of the eye made? The answer is ciliary body. And how is it cleared from the eye? I hope they mention it. They do here. It's cleared out by the trabecular mesh into the canal of Schlemm and also the uvascular pathway. So, conjunctivitis. Conjunctivitis is an inflammation of the conjunctiva, which is the layer that is covering the, if we say that this is the eye like this is the eyelids, of course. So this area, oh my God, this area, this is the conjunctiva. So in conjunctivitis or conjunctivitis, you will see a red eye. It can be allergic or it can be bacterial or viral. You must be able to differentiate between the causes for the sake of prescribing treatment. If it was itchy and bilateral, two sides, it cannot be bacterial. Bacterial most likely affect one side, so it must be allergic. Okay, good. So for that, which treatment you will give? Antihistamines, diphenhydramine. If you hate the patient or if you like him, you can prescribe loratadine or cetirizine, right? So bacterial, it's pus, and you treat it with antibiotic. I want you to make a note about this. Why I want you to make a note about this? Because this is the stuff that your uncle come and ask you about that he has. So for loratadine, for the first one, prescribe 20 milligrams, 1 per os after eating. For bacterial that has pus in it, you need to prescribe antibiotic. That will be ciprofloxacin, 1%, eye drops, 3 times per day for 10 days. Regardless of the fact that it will clear out after the second day, tell him to finish the whole 10 days for prevention of recurrence. Viral is the most common one, often due to the adenovirus, if you remember, the pink eye virus, and sprays mucous membrane and can lead to swallowing preauricular nodes, lymph nodes, and more lacrimation, and is self-resolving. But it's not as itchy as the allergic one. There is no itchiness. However, what are drugs for allergic? Okay, let me just write them here. So loratadine, 20 milligram. Okay, so however, guys, to be real with you, you can use cetirizine. It's also a really good drug, but the problem is that you don't always find it. Okay, in the pharmacies. It depends on the country, of course, but yeah, this guy is awesome. Good. However, just keep in mind that loratadine make you eat like a pig. It makes you hungry, okay? So just don't use it every day. Refractive error. Oh my God, a lot of medical students have this. So refractive error. For all of you guys wearing glasses, yes, this is for you. Why the hell do you guys wear glasses? Because you like it? Because it looks cool? No. It's to correct your vision. So what does that even mean? Well, you have a refraction error. What does that even mean? Well, we have myopia, hyperopia, and astigmatism. Well, we have a lot of them. So what's wrong with you? Well, the thing that is wrong with you is the size of your eyeball. Either, let's say that this is a normal eyeball. This is the cornea, and this is the eyeball. Let's say that this is your eyeball, okay? In some diseases, you can have an eyeball that will be like this. Notice something? What's wrong with this eyeball? Yes, exactly. It's, sorry, the shape is my mistake, but it's small. It's much more shorter, right? It's much more shorter. So this is normal. This is short, super short. And this is super lengthy. Oh my God. So, as easy as it is, this is causing hyperopia, this is causing myopia. Now let's try to understand what exactly does that even mean. So the first thing first, it says, hyperopia, also called farsightedness, the eye is too short for the refractive power of the cornea and the lens. So the light will be focused behind the retina, and yeah, corrects with convex lenses. Let's try to take a look at hyperopia, because my drawing skills are bad and I would like somebody to make the scheme for me. Hyperopia. Nice. You can see that in a normal eye, our cornea and our lens are responsible for converging all of that light into our basically retina. Fovea centralis, we call it. However, in case of hyperopia, because of the eye being shorter, if you notice, it's much more shorter, right? and also problems with the cornea and the lens that can lead to the focus of the light to be located behind the eyes. That will lead to the problem inside. So how to fix that? Well, we put a lens. So initially the problem was like this. If you put this type of lens, is going to converge it before it reaches, so you are going to get it exactly at the spot. So that's why your vision corrects, basically. So we call that hyperopia. Remember, we do use a convex lens. Why? To be able to converge, right? Look here, it's converging, right? So it's convex. Myopia, also called nearsightedness. Eye is too long for refractive power of the cornea and of the lens. So it goes something like this. Nearsightedness. Eye is too long for the refractive power of the cornea and the lens. The light will be focused in front of the retina, like before it reaches the retina, and we need to diverge the light. So let's take a look at it. So myopia. Myopia is the disease of medical student. I think most of you guys have it, at least one of you. So okay, so you can see that in case of myopia, the light is being focused here in front of the retina, which is wrong. And for that, you use this type of diversion glasses, which will make it be focused on the retina again, not in front of the retina. Okay, so they write concave or diversion lenses. Astigmatism, it's pretty weird actually. It's due to a problem of the cornea itself, which is the clear stuff in the anterior portion of your eye. So different refractive power at different axes, and you correct it with a cylindrical lens. So let me show you how astigmatism means. It means that at the same eye there will be different axes of light going to it, meaning something like, hopefully I find a good picture of it. Yes, nice. So you can see that, no, not nice. Un momento. Okay, you can see how the light just hit one point and then multiple areas appear. You are like, well, what does that mean? That means when the patient will look, he will see like shadows of everything, right? Quite annoying. So it is something like, okay, you can see how this guy, for example, is seeing like this object to be much more lengthier, and he has a problem with the vision. So that's astigmatism. Okay, so they can have sometimes something like a dual vision type of thing because of this. Basically, their vision was diverged big time. The way to treat this is something called cylindrical lens. Okay, cylindrical lens. So this cylindrical lens is going to gather up everything and then push it at exactly a focal point on the retina. So that's astigmatism. Presbyopia, really common in the old population, age-related and impaired of accommodation, focusing in near objects, primarily due to a decrease in the lens elasticity. So the lens, when we get older, obviously it will have less elasticity, less collagen is going to be formed in it. So also change in the curvature of the lens can occur. This is interesting, guys. I will tell you why in a second. So decreased strength of the ciliary muscle as well can occur in these patients, and they will need to start using these reading glasses and magnifiers when they get older because of all of these problems. This is a normal aging problem. The aging problem, for the sake of the USMLE, you must master. The disturbances of the sleep, the decreased, like these patients sleeping in an improper time, waking up early. The patient having this, old people having an S-shaped left ventricular size. All of these are normal age-related stuff. It's not pathological. So the next thing is cataract. Is cataract common, guys? How do you think? Is cataract common these days? Super common. Everybody has cataract. Why? Why everybody has cataract these days? The diabetes, absolutely correct. Everybody you speak to, you just literally go to anybody, ask him, do you know a cataract patient? I'll be like, yeah, my uncle, yeah, my father, yeah, myself. Everybody has cataract because of diabetes. So it's painless, often bilateral ossification of the lens. Okay, it's pretty interesting treatment because, well, just a guess. When did we start treating cataract? When do you think somebody came with the idea that the cataract is a problem for the lens, and if we replace the lens, the patient will be cured? A little bit more early of that. It's much more earlier than this. Okay, so maybe in the modern medicine, it could be the 70s, the 80s, I'm not sure, but I can tell you this. The first operation to be done on this was 3,000 years ago. And to make you like, what the hell, it was successful, okay? And since then, a lot of people used to do it. It was really common back in the time for people from the Jewish origin because they used to be like the high thing in medicine. So yeah, they were really good at it. And also with the, like, if you go to the history of the medicine, also if you know Ibn Sina, he also used to do this operation as well. Yep. So cataract was treated even more than 3,000 years ago. That's cool. So if we cannot treat it right now, we will look like shit, guys. So I'm not kidding. We need to learn about it. Painless, often bilateral ossification of the lens. It can result in a glare and decreased vision. Really, really common. The patient will be telling you, doctor, I feel like I see like a halo around the object, doctor. I'm not sure what is this, but I see like a halo, and at night I cannot drive because I start seeing like it's hazy everywhere, doctor. And you are like, okay, well, do you have any other problem? And he's like, not really, but this is really bad, and I'm really scared to drive at night because of that. Just so hazy, I cannot even see the car in front of me. So it's something like this. Or like, okay, can I take a look at your eye? He's like, yes, please, doctor, do. So when you take a look at his eye, you see this, it's white. So there's something called the red reflex. The red reflex, if you remember back in the time, well, I'm speaking about people who were born in the previous, like 1990 something, not the new generation, because you don't know this. So basically, people in the old cameras, when we used to take a picture, remember the red eye thing? Like people used to have the red eyes on the pictures, right? And then they are like, oh, we have to Photoshop it to correct the eye color. What is the red thing? What are you seeing in the picture? What is the red thing exactly? Well, no, it's not the lens, guys. The red thing actually is your retina. Your lenses should be transparent. You should not see it. It's your retina. You're like, oh my God, so this picture that I took in my childhood, they were looking at my retina? How the hell this is even possible? Well, it's possible. So it's your retina basically. Okay, so let's say you took a picture and you saw that, oh, he has it here, but he does not have it here. That means there is something blocking the retina, which could be, in this case, retinoblastoma, a cancer of the eye, okay? But in our case, here is the cataract. So they write, it's an acquired risk factor, can be increased age, tobacco smoking, alcohol overuse, and then excessive sunlight. Oh yeah, let's stay on the beach. And the prolonged corticosteroids use, in addition to diabetes mellitus, trauma, and infection. Congenital risk factors include classic galactosemia, which we'll speak about it a little bit later. It's basically in the galactose metabolism dysfunction. So we have two diseases, the really severe one, which is this guy, galactosemia, and the mild one, which is galactokinase deficiency. Regardless, both of these lead to cataract. Trisomies 13, 18, 21 as what is the most common trisomies, guys? It is No, come on, guys. It's not 21, it's not 15, it's not 18. It was 16, and I told you that it's most common, but everybody dies. Okay, so torch infection, like rubella, can also cause this, and remember that it also can lead to... Which heart condition can be due to rubella, guys? Heart condition due to rubella. Well, I hope you are thinking about patent ductus arteriosus, PDA, that can lead to a continuous type of murmur. Cataract can appear also in Marfan syndrome, Albert syndrome, myotonic dystrophy. Remember, myotonic dystrophy, it was that guy who do the handshake and cannot let go, if you remember. They mostly die from arrhythmias. And neurofibromatosis type 2. Okay, now we are going to speak about the aqueous humorous pathway, where it is produced, where it goes, and what will happen. Why they are so precise about it? Because if the pressure inside of your eye increases so much, which condition you will develop? Glaucoma. Exactly. That's why we are learning this topic. So basically, the aqueous humorous is produced by the ciliary body, this guy. So they say, produced by a non-pigmented epithelium in the ciliary body, and you can decrease the production by many ways. And why would I decrease it? Well, for example, as you said, glaucoma. So you can decrease it by beta blocker like tamilolol. However, you should give it topically. I mean, in the eye, not to give it like in the veins or something. And alpha-2 antagonist like brimonidone, which also, well, alpha-2, which G is it associated with? Which G protein is bound to the alpha-2? GI, so that is going to inhibit the ciliary body production. Also, carbonic anhydrase inhibitor like acetazolamide can decrease the production of the ciliary body. Okay, anyway, the ciliary body, when it's produced, is going to go to the posterior chamber and then to the anterior chamber. And then it's going to go to the trabecular meshwork and gets cleared up by the canal of Schlemm to the epicicleral vessels, or it can go through the least common UV scleral outflow. I like this one. You will know why in a second. So, anyhow, so let's speak about what happens if the iris, if we have like, pubuloconstriction or pupilodilatation, what will occur? So the iris mediated by alpha-1 will have the dilator muscle working, and the M3, which is the parasympathetic, will have it closing. So let's try to think, what's up? Okay, so let's say patient X has a glaucoma, and you give him atropine. What will atropine into somebody's eye do to the eye? Atropine block the M3. So what will happen to the eye? Is it miosis or mydriasis? No, guys, atropine blocks the M3. It blocks the M3. M3 is a sphincter, so it constricts. When I block a constrictor, I will dilate. Okay? So, okay. So when I say the iris should dilate, it means it should go this side, right? So it's going to become big, and just because, all of this space is needed to go into one big area. So it will look like this. This the iris will be, right? If that is the case, what is the iris blocking now? Trabecular meshwork, absolutely. So if it will block the trabecular meshwork, there is no chance for the aqueous humorous to drain, meaning the pressure inside of the anterior chamber will increase. A lot of people tell me, okay, so the pressure is increased. This is a glaucoma, got you. But how this is even lethal? How is this even bad? Well, when the pressure increases here, obviously it's going to increase here. And if it increases here, obviously it's going to increase inside of the vitreous chamber. And if it's going to increase inside of the vitreous chamber, it's going to increase where? Here. Where is here? Here is the optic nerve. When it's going to increase on the optic nerve, the patient visual field initially will have a blindness of the periphery that is going to continue until the patient becomes totally blind. Okay? So here they write the following. We have the aqueous humorous draining, and then we have the canal of Schlemm. So they write trabecular meshwork, drainage through the trabecular meshwork, the canal of Schlemm, and then the epicleral vessels. And it's going to increase with an agonist of the M3, like carbachol and pilocarpine. Okay, which is really commonly used, especially the pilocarpine. The uveoscleral pathway, the least common pathway, it also can drain, and the prostaglandins help with it, like lantoprost and bimatoprost. Why I like it? Because these prostaglandins agonists have some side effects. Their side effects is something that the ladies do it on purpose to give the side effect. What is it? Well, ladies who use lantoprost and bimatoprost onto their eyes, they will have much longer, just a second, in English, eyelashes. Okay, they will have much longer eyelashes. You are like, nice, so eyelashes will be longer. Nice, that sounds good. Yeah, but keep in mind that your iris will become black. Okay, so it darkens the iris color, but in the same time it's make the eyelashes longer. Just keep that in mind. It's given topically, and that's it. Okay, glaucoma. Optic disc atrophy occurs because of the increased intraocular pressure, so with characteristic cupping. So what is the cupping? Let's take a look. So this is the optic disc, and you can see the opening here is pretty small, but what will happen that it becomes huge. Somebody asked me once, well, I cannot see the opening actually. Look for the light. So when the light is like pretty sharp, that's the inner border. When it becomes less, it's the outer border. So let's see what they write. Optic disc atrophy with a characteristic cupping versus thinning of the outer rim of the optic nerve head. It usually happens with an elevated intraocular pressure and a progressive peripheral visual field loss if untreated. So treatment is through pharmacological or surgical lowering intraocular pressure medication. Okay, so let's see which type of glaucoma we have. We have two main types. We have the open type and we have the closed type. The open type is pretty interesting, I have to say. It most commonly to take some time for it to happen. So increased incidence in the old people, plaque population, and patient with a family history of the condition. It's painless, and this is super important to know that it's painless because the other one is painful. And it's the most common in the US, and it's a chronic type of disease, meaning that it's a progressive, happens slowly. Primary is idiopathic. We don't know why it happens, but it could be secondary, meaning that we know why it happens. Like, for example, due to a block of the trabecular meshwork, right? By uveitis and inflammation of the uvea. Somebody will ask me, well, you did not tell us what is uvea. Uvea is the combination of the iris, ciliary body, and the choroid. So choroid, iris, ciliary body, together we call them uvea. The RBCs, vitreous hemorrhage, and retinal element, retinal detachment can occur in these patients. However, there is a few more points I would like to clarify here. In case of open angle glaucoma, the patient will have the vision loss like the closed angle, initially starting at the periphery of the eye visual field, but then goes more centrally. Okay, so the next thing goes something like this. The closed and why do we call it open angle glaucoma? Because in that case, it's not actually a problem of production or a problem of passing forward. It's open angle. The angle here is open, but the problem is here at the trabecular meshwork. Okay, so it's a drainage problem. So closed or narrow angle glaucoma. So the primary, it could be an enlargement or anterior movement of the lens against the central iris, the pupil margin, which is this guy here. So this will move forward, blocking the flow. So if this will occur, obstruction of normal aqueous flow through the pupils, so the fluid will build up behind the iris, pushing peripheral iris against the cornea. So as you can see, now the iris is getting pushed forward, and now we have narrow angle, as you can see, narrow angle or an acute angle, right? So they say, and embedding the flow through the trabeculum meshwork. So basically, because you are reducing the angle, you are blocking down the mesh. So they write, secondary causes can be hypoxia from retinal disease like diabetes or vein occlusion, which will induce vasoproliferation. And when that vasoproliferation will occur inside of the lens, it's going to push and close up the angle as well. So that's also a case. So they write here the following. Chronic closure, often asymptomatic with damage to the optic nerve and the peripheral vision. So as we said, the patient will have loss of the peripheral visual field, and then progressively comes more central. While the acute closure, like the patient is completely normal and suddenly it's shut. I mean the angle of the passage here is shut. So what is going to happen in this patient? Acute closure glaucoma. A true ophthalmic emergency, the patient will have a horrible headache. That's his complaint. So there will be more intraocular pressure pushing the iris forward. An angle closes abruptly, very painful with a red eye, as you can see here. Sudden loss of vision, the whole thing. And the patient will also have this frontal headaches, halo around the lights, and fixed and mid-dilated pupils. All of these are pretty severe symptoms. So nausea and vomiting, and you should be really careful with this patient. Never give them atropine. Why would I give them atropine? Well, mostly ophthalmologists like to give atropine or other medication to open up the pupils to look at the retina. But in this case, it's completely contraindicated, okay? Uveitis is an inflammation of the uvea. Can somebody tell me the structures of the uvea? What is uvea composed of? Ciliary body, the choroid, and the iris. Excellent, good. So in the uvea, inflammation of the uvea, a specific name based on the location within the affected eye. So yeah, anterior uveitis, posterior uveitis, iritis, and it goes like this. Choroiditis or retinitis, according to which structure is affected exactly. So it may have hypobion, which is this thing. The pus is accumulating inside of the anterior chamber. Accumulation of the pus in the anterior chamber of the eye will lead to hypobion, which is this thing, or conjunctival redness. So it's associated with systemic inflammatory condition like sarcoidosis, rheumatoid arthritis, juvenile idiopathic arthritis, and the HLA-B27. Does anybody remember what is HLA-B27 disease? The barium mnemonic, which is psoriasis, ankylosing spondylitis, inflammatory bowel disease, and R4 reactive arthritis. Okay, good. So, nice. The next thing we are going to speak about in 10 minutes after the break. See you in 10. Okay guys, welcome back. So next thing is going to be about age-related macular degeneration. So the first question is, what is the macula? So the macula of the eye. So the macula basically just an area in the eye. So here we have the optic disc, here we have the macula, okay? Inside of the macula, there is an area called fovea centralis. The macula contains the most amount of the cones of the eye. So the cones are most likely to be located inside of the macula. Okay, the blind spots is the optic disc, meaning it does not have a photoreceptors. So age-related macular degeneration, degeneration of the macula, which is the central area of the the retina, Please remember, our retina is made up of 10 layers, not one layer, not two layers, 10 layers. And the lowermost layer is made out of the photoreceptors, okay? So it causes distortion of the straight lines. They will tell you that it's actually pretty specific. It is, on the USMLE, they say wavy doors, wavy doors. So everything starts looking wavy. So let's take a look at that. Oh my God, what I'm doing. Yep, so when you do this test for them, they will see something like this. This will look like this. The blind spots will be more abundant, and the USMLE in general, it will be the wavy door, okay? So actually, to do the test, just you can test yourself right now. Do you see it wavy or straight lines? If you see it wavy, go to your ophthalmologist, okay? So the next thing goes like this. Let's see, that's macular degeneration, mostly in all people. So causes distortion of the straight line, which is known as metamorphosia, and an eventual loss of central vision, which is known as a scotoma. A scotoma is absence of the central vision, which means something like this. This is a scotoma. This is a scotoma. Okay, so it has two types. We have the dry and the wet one. The dry one, it happens because of a deposition of an extracellular material known as a drusen. Drusen is yellow. I hope you can see the yellow little structure dispersed all over the place, the yellow stuff. All of this is a drusen. So it's going to be located between the Bruch membrane and the retinal pigmented epithelium. Let me explain this point. So basically, the retina, as we just said, it has 10 layers, right? So these layers, the lower ones, we have like this basal layer basically, and we have this photoreceptor layer. Between them, there is this yellow pigmentation that forms, and that is drusen in macular degeneration, okay? So you can see here the drusen, the acute form of macular degeneration. Okay, so they write here scotoma. Scotoma is absence of central vision. We spoke about this. The patient is going to have decrease in the vision progressively. Please keep in mind, the patient will initially lose the vision centrally, and then it's going to go to the periphery. Do you remember in case of a glaucoma, initially the vision loss was in the periphery and then went centrally? So a preventive progression with multivitamins and antioxidant supplementation. Which 3 vitamins are considered to be antioxidant? Vitamin A, vitamin E, and vitamin C, okay? If you forget about them, just remember the mnemonic ACE, A-C-E. Okay, so antioxidant supplementation. Well, that does not sound like a really treatment. There is nothing to cure it. You are just preventing the progression. Yes, that's actually true. You're just preventing it from getting worse. However, the wet one, we actually can cure it. It's less likely to have it, and it's most likely to be because of diabetes and old age, rapid loss of vision due to bleeding secondary to choroidal neovascularization. So new blood vessels are going to start forming inside of your retina, and it's going to look something like this, the new vascularization, I mean. So you can see a lot of new blood vessels are forming, and even some bleeding, meaning that one of these vessels just exploded, right? So that is going to lead to this bleeding inside of the retina. So how to stop it? Well, the way to stop it is by an injection. So you need to give the patient anti-VEGF, which is the antivascular endothelial growth factor that decreases the new vascularization, prevent the new vascularization from occurring, curing the patient. So there is a big problem. So that it's given by an injection like bevacizumab and ranibizumab. What do you think? Where should I give the injection? Well, exactly, in the eye directly. Is it scary? Yeah, it is. And do we do it on the patient while he's awake or he is asleep? Awake, yep. And is it painful? No, not really. Because we just, like, we put anesthetics, so he feels nothing, but he can see everything, which is scary. I mean, I really don't want to try it in my life. It's super scary. So, but anyhow, it's curable. It's the wet one is curable. The dry one, you just stop the progression. The next one is diabetic retinopathy. Retinal damage due to chronic hyperglycemia. What other eye condition we spoke about was due to the diabetes? Cataract, yes. So we have a non-proliferative and the proliferative. And the non-proliferative one is because of a damage of the capillaries and destruction of the capillaries, leaking blood into the retina. So there will be lipids and the fluid leaking to the retina, and eventually the leakage of the blood will lead to hemorrhage, as you can see all over the place here. So, and macular edema. So the treatment is blood sugar control to make sure everything is within normal ranges, okay? So we have the other types, which is the proliferative. So the proliferative one is because it's happening because of the hypoxia. Again, the idea when you have hypoxia, you will start to have formation of new vessels. So results in a new vessels formation and with a resultant traction of the retina. So basically the new vessels formation, they can pull, remember, the new vessels are in the choroid, right? So they can, basically, this is the sclera, this is the choroid, and this is the last layer, which is the retina. When this enlarges so much, it can detach the retina, okay? So proliferative chronic hypoxia results in a new blood vessels formation with a resultant traction of the retina, leading to retinal detachment. So the treatment is with the anti-VEGF injection and peripheral retinal photocoagulation to destroy the small blood vessels as well, and surgery. The same idea, it's an injection into the eye, which is not the most comfortable thing. The next thing is a hypertensive retinopathy. Hypertensive retinopathy goes something like this. Since in people with chronic uncontrolled hypertension, they will have an endothelial disruption of the blood vessels, of course, leading to fibrinoid necrosis, which is mostly seen in the brain, and retinal damage. So the cool thing about it, the shape of it, it sounds so much like the diabetes, but the history is helpful. So flame-shaped retinal hemorrhage can be seen all over the eye. Arteriovenous nicking, I hope I can find a picture of that. So if you close up, just a momento. Okay, good. So maybe you can see here the necking, which is the like this twist with the whitish stuff in it. Also, do not, oh, okay, this one is even better. So you can see here how it's like boom, right? That's arteriovenous nicking. And okay, this is even better. You can see, I like this. This is normal. And this is the nicking, okay? You can see how it's like messed up here. Okay. So the next thing goes something like this. They write, yes, microaneurysm can form, which can basically bleed. That's why we have the retinal hemorrhage. And also they can have an exudative release. So all of this stuff here, this is not hydrosin, it's a hypertensive patient. It's going to be instead exudate. Cotton wool spots can be seen all over the retina. This is not specific for this disease. It can be seen in diabetes as well. And the presence of papilla edema requires immediate lowering of the blood pressure. Why? What is a papilla edema a sign of, guys? What was the papilla edema a sign of? Increased intracranial pressure, absolutely. So if you see that, you must lower the blood pressure because this patient has high risk of stroke. Okay, it's associated with increased risk of stroke, coronary artery disease, and kidney disease. Hypertension. Retinal vein occlusion. So if this is an organ, this is artery, and this is vein. What happens if I block the vein? The blood inside of the artery is going to, the blood inside of the organ is going to increase, right? And accumulate. So yeah, that sucks. So let's see what that will lead in this case. A blockage of a central or branch of the retinal vein due to the compression of a nearby arterial atherosclerosis. Anyhow, there will be retinal hemorrhage with venous engorgement, which is a lot of blood inside of the vessels. Blood and thunder appearance on the visualization of it because of the engorgement. Edema in the affected area will occur as well. Okay. The next thing to speak about is the retinal detachment. Retinal detachment is quite like a thing of people who has like trauma, guys. It's really, really famous in trauma. So separation of a neurosensory layer of the retina. Remember the retina was directly located above the choroid. So photoreceptors layer with the cones and rods will be separated from the outermost pigmented epithelium, which normally shields us against excessive light and supports the retina, this layer normally. So degeneration of these photoreceptors will lead to vision loss. Shit. Okay, so it's just the retina slipping off. Can we just put it back on its place and the problem will be solved? Nope. The patient is screwed. So the idea is like this. It's not reversible. It may be secondary to retinal breaks, diabetic traction, and inflammatory affection. Remember, the diabetic traction can happen because of massive neovascularization of the choroid leading to the retina to get detached. Visualized on fundoscopy as a crinkling of the retinal tissue on the side. It's like you bring a paper and crinkle it on each other. It looks like it. Okay. So, and changes in the vessel direction. Okay, good. So the next thing, breaks more common in patients with a high myopia or history of head trauma. So often preceded by a posterior vitreous detachment. So the patient is going to have flashes and floaters. This is really, really common. Be like, doctor, I had this flashes, and then some curtain fell into my face. Eventual monoocular loss of vision, like a curtain drawn down on their face. The treatment is surgical emergency. You cannot basically cure the patient. You can just only prevent the progression. Central retinal vein occlusion, retinal artery occlusion, first of all, goes something like this. In this disease, you are going to see a red spot on the macula, as you can see in this picture. So acute, painless monoocular vision loss happens suddenly. Retina is cloudy when attenuated vessels and cherry red spots on the macula. So there is other diseases that lead to a cherry red spots on the macula. Please make notes. Cherry red spots in the macula can be seen in central retinal artery occlusion. Cherry red spots in the macula can also be seen in two only other disease. Tay-Sachs disease, which is a lysosomal storage disease, and Niemann-Pick disease, which is a lysosomal storage disease. So Tay-Sachs and Niemann-Pick, which we'll be both discussing in metabolism. Evaluate for embolic source. Well, it happens suddenly, so it should come from somewhere. So it could be the carotid artery atherosclerosis emboli or cardiac vegetation emboli. Also, it could be coming from lower extremity from a BDA. So the next disease is something known as retinitis pigmentosa. Retinitis pigmentosa, it's an inherited progressive dystrophy of the retinal pigmented epithelium and photoreceptors. Okay. So basically, it can be associated with a disease known as A-beta lipoproteinemia, which we'll discuss in lipid metabolism. In this disease, basically, there is a problem in the lipid metabolism, and the patient will have vitamin E deficiency. Vitamin E deficiency. Early findings are including nyctalopia, which is night blindness, and the peripheral vision loss. In addition, fundoscopy may show a triad of optic disc palo, retinal vessel attenuation, and retinal pigmentation with a bone spicle-shaped deposit, which is something like this. I just imagine somebody with some type of a brush that brushed everything around, and well, pigmentosa. It will be black. That's the idea. Babble edema, it's due to an increased intracranial pressure, and if you see it, it's a bad sign. A lot of times it means like there is a tumor inside, or it could be stroke, something like this. Optic disc swelling, due to increased intracranial pressure, usually bilateral, so the babble edema. Oh, why this is important? Actually, there was a guy, he's from Palestine actually. He was able to make eyeglasses, okay, that you put on your eyes, and it can tell you if you have a stroke or not. And initially they thought it was a joke. The man is a neuroscience. He's not joking. And yeah, basically he won like a, I don't know, I think you call it a trophy in Britain for that, and he got funding with $5 million to continue improving his glasses. These glasses can catch a stroke earlier, and they can catch it in the clinic without doing the CT scan by checking the exact pressure of the eye. And if the pressure inside of the eye is increasing, that means the babble edema is pushing the eye forward, which is a way to calculate the intracranial pressure without having to do a lumbar puncture. Really smart idea. So optic disc swelling due to increased intracranial pressure due to the mass effect. The patient will have an enlarged in the blind spot. Remember, the blind spots was in which area of the eye normally? Let me try to trick you. Is it the macula or the optic disc? No. Okay, let me prove for you. Which area had the most amount of cones? The macula. So can the cones see? They can. So this cannot be the blind spot. The blind spot is in the optic disc, okay? Where the nerve goes, basically, okay? Nice. So leukocoria, which basically means the white eye, and the loss of the red reflux we spoke about with the camera, important in congenital cataract, which can be in galactose metabolism disorder, and also in retinoblastoma, it can be seen. Remember, retinoblastoma is highly associated with bone cancer like osteosarcoma. Okay, guys, let me just take a quick look. Okay, guys, that's enough for today. I will continue with you guys tomorrow. So until tomorrow, see you guys.